at the university. And it is my absolute pleasure today to introduce Jenna Sopfe, who's one of our pediatrics faculty members. Many of you have met Jenna in a number of different circumstances on campus, but just a little brief bio. Jenna is a Californian by nature and actually did her undergraduate work at UCLA and was a summa cum laude graduate of UCLA in psychobiology before attending medical school at Vanderbilt University. Following med school, she came to residency here in the Department of Pediatrics at the University of Colorado and Children's Hospital. And we were fortunate enough to get her to stay for her pediatric Heme fellowship, which she completed in 2018, during which time she also completed a Master's of Clinical Science in the Clinical Sciences program here, and is most recently a graduate of the Accords and SCORE program that many of you have also come to know. So it's a pleasure to have gotten to work with Jenna across a variety of her experiences and her training, and to welcome her as a member of our solid tumor team. Jenna has a strong interest in cancer survivorship, in functional survivorship, and has worked with some of you on the adult side in our tactic clinic in transitioning survivors of childhood cancer into adulthood. And I'm really excited to hear the next generation of projects that she's working on. One of my real enthusiasms around this is the interaction that I would like us to increasingly have between the pediatric and the adult programs, and how we transition survivors of cancer at all ages to a healthier, better, and higher quality of life. So it's a pleasure to introduce Jenna. Thank you all for joining today. And I hope this will be a fun and dynamic presentation about how we can do better for our patients. Thanks, Jenna.
Thanks so much, Leah. And again, thank you all for being here. I'm hoping that my screen share looks right to you all. And I have been advised by Jill to recommend that any questions, just go ahead and put your name in the chat, and then we'll come back to you at the end instead of typing all of them in there at the moment you have it. So anyway, as Leah said, I'm interested in solid tumor oncology as well as survivorship. And I'm going to be talking to you today about my work using a stakeholder-engaged approach to addressing sexual dysfunction after childhood cancer. So first, I'm going to just outline what we're going to talk about. Sexual and reproductive health, and in particular, sexual dysfunction, is an unmet need of many adolescent and young adult childhood cancer survivors. So in this talk, we'll first define sexual dysfunction, followed by outlining its prevalence, discussing pathophysiology, and reviewing current treatment options. I'll then review the current state of diagnosis and treatment for sexual dysfunction after cancer and discuss some patient-recommended opportunities for improvement. By the end of the talk, I hope you'll understand the nature and extent of this problem, why it's an unmet need, and how we can move forward in addressing it. First, I'll step back from sexual function specifically and define sexual health. According to WHO, sexual health is fundamental to the overall health and well-being of individuals, couples, and families. It encompasses sexual orientation, gender identity, expression, sexual and romantic relationships, sexual dysfunction, sexually transmitted infections, and sexual violence. Based on what is known about cancer's effects on sexual health, today we're going to focus on sexual and romantic relationships and dysfunction. The ability of men and women to achieve sexual health and well-being depends on their access to comprehensive, good quality information and about sex and sexuality, knowledge about the risks they may face and their vulnerability to adverse consequences of unprotected sexual activity, ability to access sexual health care, and living in an environment that affirms and promotes sexual health. I'll also just briefly mention reproductive health issues, including fertility and maternal health, are very important after cancer as well. However, these are much more well recognized and addressed through fertility programs here and elsewhere. And so we're going to focus on this other component of sexual health. To further define what we're talking about with sexual function, these challenges are very wide-ranging. They can relate to issues related to desire, satisfaction, pleasure, physical arousal, difficulty with or inability to orgasm, anxiety or worry about sex, climaxing or ejaculating too rapidly or with difficulty with this, or physical pain during intercourse, among other issues. Somewhere between 20 and 50% of childhood cancer survivors experience sexual dysfunction, which is higher than in non-survivor populations. This is demonstrated across a number of studies, and I've selected a few figures to review. This first one demonstrates that various types of sexual dysfunction in female childhood cancer survivors, or CCS, in blue, compared to sibling controls in orange. This study was actually one of the more conservative estimates for sexual dysfunction, with about 20% experiencing it. However, all domains of sexual dysfunction, except for activity and relationships, were significantly higher than in sibling controls. Similarly, in this study of male survivors of childhood ALL, you can see that there was a significant difference in sexual dysfunction rates between survivors, represented by the dotted line, and the controls. Importantly, this issue persists, and in fact, as you can see, worsens over time. As in females, a number of sexual dysfunction domains, including arousal, behavior, orgasm, and desire, were affected in this cohort. As you might expect, problems with sexual function can have serious effects on patient quality of life, including bodily pain, general health, vitality, social functioning, energy and fatigue, physical quality of life, and mental health. While study results vary in their evidence of an association between sexual function and quality of life, a number of the larger studies do demonstrate such an association. So in this figure, you can see that quality of life domains, which are represented across the x-axis, are significantly lower in female survivors who have sexual dysfunction, represented in blue, than those who do not, represented in orange. Of course, addressing and interpreting the association between sexual dysfunction and quality of life is hard. There's a bit of a chicken and egg issue. These are interlinked and they may have causality in both directions. However, several studies do demonstrate that actually addressing sexual dysfunction results in decrease in psychological distress overall. Importantly, sexual function is incredibly complex with biological, psychological, cultural, and interpersonal factors. Therefore, understanding, predicting, and addressing sexual dysfunction is equally complex. Biologic factors may include hormone changes, medical or anatomical problems that affect genital sexual response, psychological factors such as depression, anxiety, body image, or stress or concern about fertility, interpersonal factors including relationship status and communication, and sociocultural factors, attitudes about menopause and aging, attitudes about illness, and as well as religious, cultural, and other social values. Researchers and healthcare providers must consider all of these factors when addressing sexual function, and importantly, each of these areas can be affected by the experience of childhood cancer. This is a model for the pathophysiology of sexual dysfunction related to cancer survivorship. There are many potential reasons for challenges related to sexual function in childhood cancer survivors, and often the pathophysiology is multifactorial. For example, some, but not all studies demonstrate that alkylator chemotherapy is a risk factor for sexual dysfunction, likely related to its effects on hormone function, such as premature ovarian failure and hypogonadism. Notably, though, other studies suggest that any chemotherapy may be a risk factor. The pathophysiology there is a little less clear. Similarly, radiation to the pelvis not only causes commonly recognized late effects such as fertility and hormone production, but can also be associated with concerns that arise as patients mature: erectile dysfunction, vaginal scarring, shortening or drying, and decreased blood flow. Cranial radiation can affect sex hormone production as well as normal psychosexual development, and central nervous system, spinal, retroperitoneal, and pelvic surgeries can also affect sexual health and function through nerve disruption, changes in vaginal anatomy, or in the case of CNS surgery, changes in normal development. Just as these effects can be detrimental to physical health and reproductive ability, they can have profound impacts on mental health and quality of life. Despite all of these potential biologic factors, they have not, as a group, been consistently able to predict sexual dysfunction across studies. This is likely due to the significant psychosocial factors at play. Experiencing childhood cancer, even in the absence of risk factors, can be disruptive to normal childhood and adolescent development. including psychosexual development. Childhood cancer survivors also can experience challenges related to forming romantic relationships, body image, and other related concerns that may in turn affect sexual function. I'd like to summarize some of the risk factors that prior studies have identified. Patient risk factors may include female sex, older age at diagnosis, older age at evaluation, low income, mental and physical health problems. Treatment-related risk factors we went over a bit: chemotherapy, retroperitoneal lymph node dissection, cranial, testicular, or pelvic radiation, pelvic surgery, treatment with ovarian suppression, and sex hormone dysfunction may all come into play. Psychosexual factors associated with concerns about body image, disruptions of normal physical, mental, or emotional development, and alterations in relationships during and after therapy do exist after childhood cancer. Because these factors are all complex and interrelated, again, predicting levels of risk for sexual dysfunction is difficult. And as such, all patients, do warrant sexual dysfunction assessment and education as part of their long-term follow-up care. Getting into patient care a little bit more, several oncology organizations make broad recommendations related to addressing sexual dysfunction among cancer survivors. For example, the Children's Oncology Group suggests screening for sexual dysfunction, specifically in male survivors who underwent pelvic or spinal surgery. The American Society of Clinical Oncology recommends that oncology teams should initiate these discussions both in treatment planning and periodically during follow-up. And the NCCN asks that providers regularly ask about sexual function, consider using a screening tool, complete a broad H&P for any medical concerns related to this, and review the patient's medical history, medication history, etc., before working up or referring as indicated. As you might agree, I find these guidelines pretty general. In the case of childhood cancer survivors, it's limited to a really specific population and doesn't take into account that many other patients, not just male survivors who underwent pelvic or spinal surgery, experience sexual function problems. Further, these recommendations don't specify anything about what specifically to ask, how to ask, or how to address concerns once they arise, whether it be a workup, recommendations for appropriate evaluation or referrals, etc. In addressing management of sexual function in CCS, there are no specific childhood cancer survivor recommendations, but there's also a paucity of quality treatment-focused literature in the adult population as well. The most useful guidelines that are published are by ASCO. They went through the existing intervention literature and recommended treatments or interventions summarized by each type of sexual dysfunction. Across sexual dysfunction concerns, the most common recommendation was some amount of psychoeducation, whether it be psychosocial or psychosexual counseling, CBT, couples counseling, or education. And then other interventions were specifically recommended for various other types of sexual function concerns, including things like pelvic floor physiotherapy, vaginal agents such as moisturizers, dilators, lubricants, estrogens, or lidocaine, phosphodiesterase inhibitors, intracavernosal injections and prostheses for men, and SSRIs or SNRIs to address some of the psychological components. So in addressing sexual dysfunction in an individual survivor, we might want to imagine that this is the ideal flow. The patient's screened, it's recognized that the sexual function exists when it does, and any necessary medical workup is completed with ensuing referral and treatment. Unfortunately, though, we have problems at every single stage. Screening rarely happens according to both patients and providers due to a number of barriers that we'll talk about in a moment. Recognition, even when screening happens, it may not be adequate. For example, particularly among younger CCS, such as adolescents and young adults, there may be a hesitancy to disclose a concern, or providers don't ask the right or detailed enough questions. In my own experience, even as somebody who's very concerned about this topic and wants to make sure I'm addressing the full span of quality of life, I still find this difficult. It's easy to ask the general question, do you have any questions or concerns about how sex is going for you? And most often the patients, like a 18-year-old male, for example, are going to say no, even if they do. And maybe the question's not specific enough, maybe they got uncomfortable. If they're uncomfortable, then I'm in turn uncomfortable for them, and we move on without getting into the details. So we need to clearly work on a better way to do this. Medical workup is often inadequate as well because providers may not know the workup to do or who to refer to. And as previously indicated, treatments exist, but the strength of evidence is not great. And so this area needs work as well. Further, even if there is a treatment, patient adherence, payment, or resources may be other barriers to care. As I alluded to previously, numerous studies highlight the fact that sexual function concerns go unrecognized and untreated among AYA, CCS, and adult CCS alike. Specifically, there's inadequate screening and recognition, with 82% of oncologists and 62% of internists reporting rarely discussing sexual function with their adult survivors. There's also inadequate support and treatment. In several qualitative studies, all or nearly all adolescent and young adult childhood cancer survivors reported inadequate clinical support. Importantly, they also nearly universally reported that they would like for this issue to be addressed. They'd like education and screening done by their provider. An example of this in more concrete detail is that a pretty large study of female cancer survivors found that only 2.9% with sexual dysfunction reported receiving any help or intervention for this. This brings me to my area of focus, improving screening and diagnosis of sexual dysfunction among AYA-CCS. My work is guided by dissemination and implementation frameworks and theories. Specifically, I'm working with my mentors to develop an AYA-friendly approach to screening for this sensitive topic. Designing for dissemination is an active process that helps to ensure that health interventions are developed in ways that match well with the stakeholder needs. Using a D4D approach or designing for dissemination approach in this early stage is strategic. It will help to inform our future larger studies to maximize the potential impact of sexual dysfunction recognition on quality of life for AYA-CCS. Excuse me. So first, to do this, it's important to understand what barriers to communication and screening exist. Patient-identified barriers include discomfort, both their own and acknowledging provider discomfort. They also report on contributors to this, like lack of rapport with their providers, differences in gender or age between themselves and their clinicians, and then a separate issue of potential privacy concerns and presence of family. Provider-level barriers also significantly mention discomfort, both, again, their own and of patients, lack of knowledge or experience, lack of resources or referrals, low priority or limited time, lack of rapport, again, or privacy concerns. The AYA population in particular may be vulnerable to discomfort because their own providers, by themselves and their providers, because discussing SD is a result of developmental stage, concerns about confidentiality, and they may be more likely to withhold any concerns that they do have. To explore these barriers and possible solutions, I worked with a team to perform a qualitative study. This study included semi-structured interviews, performed by a trained qualitative research assistant, as well as cognitive interviewing to evaluate an existing adult screening tool. We interviewed 24 childhood cancer survivors diagnosed before 18 and age 15 to 24 at the time of the study, who had sufficient cognitive functioning, were English speaking and reading, and had received at least chemo or radiation. They needed to be a couple years off therapy to be really focusing on this survivorship group. And we did do purposeful sampling across this age range and across sexes to try to get a good representation of this group. For this study, the first aim was to describe AYA-CCS perspectives on implementation of screening for sexual dysfunction. For example, we first asked them about prior experiences they'd had and how those conversations went. We asked them about what their biggest concerns about talking about sex with their doctor would be, and in an ideal world, what would be the most comfortable way to be asked these questions. We really pried into this a little bit to get more detail for our future intervention development. The second portion of this study assessed the PROMISE SexFS brief. This is a screening tool developed through the NIH PROMISE tools that's validated specifically in adult cancer survivors. The mean age of the cohort, the validation cohort though, was 59 years. So you might imagine that 15 to 24-year-olds may be a little bit different than a 59-year-old cognitively, developmentally, or sexually. So we felt like evaluating this screening tool specifically in this population was an important step before we went on to use it. But we did this through a think aloud method. So this means that participants completed the screening questionnaire, which was about 12 to 14 questions, while they thought out loud and expressed anything that was going through their mind. We then followed with a brief cognitive interview with questions about how the questionnaire was for them. Were there questions that didn't make sense or that they had issues with it? Were there questions that felt particularly relevant or irrelevant, among other questions? Data analysis was performed using a qualitative iterative approach guided by thematic analysis. This analysis type summarizes key features of a data set, highlighting common threads and differences across data to understand patterns. So the flow looked like this. The first recorded interviews were professionally transcribed and entered into qualitative data software. A research assistant and I independently read through a few transcripts to develop and apply a set of inductive codes to a subset of these transcripts. We then met as a team to review our respective code lists and coded transcripts, reconciling discrepancies into the code definitions and applications. We continued in an iterative way until a final codebook was established. Then the codebook was used to applied to the rest of the transcripts. Ultimately, we double coded about a quarter of all transcripts. Codes were clustered into related categories to guide theme development, and these themes are organized into an overall framework to describe patient preferences for sexual function screening and communication. In addition to analyzing preferences and experiences of this younger AYA cohort as a whole, we did explore whether responses or experiences differed with age or sex. So first, just to briefly review our study population, it was 24 AYA-CCS, 14 were female, and 10 were male. 10 were in the age of 15 to 19, and 14 were 20 to 24 years old, so slight increased representation for both females and older participants. As expected for our population, the majority were white and non-Hispanic. So first, just to get into some general themes, we confirmed findings of several prior studies that I previously discussed. Participants widely reported that their sexual dysfunction needs, including education, screening, and treatment, were unmet, and that their prior experiences with sexual health conversations primarily focused on fertility and safe sex, whereas discussions of sexual dysfunction were either absent or truncated. Participants identified that the most significant barriers to productive conversations were discomfort both from themselves and providers, and mentioned some additional barriers such as difficulty initiating these conversations. They wanted their provider to do so, worries of being judged, and rare concerns of privacy. AYA-CCS did identify several existing and potential factors that reduce or have the potential to reduce these barriers, with many having a common central theme of the importance of rapport. Themes for the AYA-CCS preferences for implementing sexual dysfunction conversations into practice were grouped into categories of who, how, when, and where, which we'll go over now. First, who should have these conversations? It was really interesting to see that AYA-CCS really focused on rapport. They felt like this would reduce discomfort, allow conversations to be tailored to them, and have a less fear of being judged. Interestingly, when we asked which types of providers this would be for them, there was a mix, although many participants identified their nurse or nurse practitioner as meeting this need best. There were some participants who did identify their oncologist or primary care provider. An example quotation for this, for evidence, is that it's like one-on-one, so it's more personal. It relates to me, and it's not just general, because some stuff I feel like just maybe can't apply. So this gets back to having it be a more tailored conversation because of rapport. Participants also felt like it was really important that providers are educated on the topic and on their cancer history so that they can talk intelligently about how their cancer history or treatment history may have affected sexual function, and then also know what to do with the information. Participants did acknowledge that the specialty itself wasn't important as long as the provider could at least ask some basic questions and refer them and educate as needed. Here's a couple example quotations here. Well, an oncologist would understand exactly how cancer would affect these things. Another said, I wasn't sure if someone who is trained in practices with children would now be able to answer questions I had now as a young adult. So really thinking about making sure that the training is appropriate for this. Lastly, a number of participants acknowledged that they would feel more comfortable if the provider's gender or sex was matched to their own. Obviously, this is a slightly more difficult to implement recommendation, but is notable. For how these conversations can occur, first, patients really appreciated the idea of advance notification. So they felt like this reduced discomfort, allowed for an explanation of the reason for asking these questions, allows them time to consider any questions or concerns they have, and give them a chance to opt out if they really don't want to. For example, one patient said, I think if there was maybe a way to notify someone that they would need to talk about this, then there's not that whole shock like the first time it's brought up. Participants also like the idea of written materials, which allow them to feel prepared, help with understanding, and help remember potential areas of concern. An example quotation here is that a cheat sheet is just simplifying it, just because, of course, people that are more than twice my age are going to have different words and stuff for things they use, and stuff for different use for different things, excuse me. Screening questionnaires are also something that participants looked upon favorably, whether they brought it up themselves or when we talked about it and used the Promise tool. Participants said a questionnaire would maybe be helpful to me in that the sense that I'd known what to be thinking about, because a lot of time I don't know how to talk about it. So the questionnaire would definitely be a way for me to hone in on my thoughts about what the topic is. Participants endorsed a questionnaire for the purpose of reducing discomfort. It was easier to be honest, facilitates conversations, can serve as that advance notification that they wanted, and generates new ideas about and questions about sexual function. Moving on to when these conversations should occur. First, participants in this study, as in prior studies, feel like these conversations should be ongoing through the cancer care continuum. Several did acknowledge that they didn't retain anything that was discussed at the time of diagnosis, and so delaying conversations or repeating them a short time later would be helpful. Participants also felt like these ongoing conversations are important because it will normalize the conversation and increase rapport, and it will also allow them to address any new questions or concerns that develop as they age and gain life experience. An example quotation here is, I think I would have liked once in the middle of treatment and then once when I'm finished up. Even now, when I'm in my follow-up period, I'd be really excited if someone talked to me about it during an appointment. Another said, I think they could probably have the conversation frequently so that it'd be a normal thing. So you know what they meant, say once you visit them again, what they might say, excuse me. So really getting at the idea of normalizing these and continuing to address it so things come, if in case things change. We also asked the when on a more micro level. When in clinic should these things happen? Conversations to increase rapport patients felt like should happen mid to late in the visit, whereas a screening questionnaire should really occur before they see their provider so they can start to think about the questions they might have. Next, where should these conversations occur? This one's a little bit easier for anyone to really guess. We got to optimize privacy, right? So that is key to any adolescent or young adult history taking that you want to have time one-on-one with patients. Of course, this is something that we are all well trained in. Interestingly, though, most participants didn't actually have significant concerns about confidentiality, citing trust and rapport with their providers and medical systems. For example, one said, as long as you're letting her know that the information is taken care of, she wouldn't really worry about it after that. We also asked about where in clinic such conversations and screening should occur. For conversations, very much so, need to be in a private place, as we discussed. For a screening tool, patients were happy with either being at home or in a private clinic space, but really universally felt like the waiting room was not appropriate. One participant said, an environment where I didn't feel like I was being looked at or had the potential of somebody looking over and seeing what I was doing. We also asked about paper versus online, just to really get into the nitty-gritty of how to do this and what's more comfortable for participants. In these young participants, we really assumed that they were going to prefer online, but it was actually quite mixed. Some felt like paper was more secure than online, and some felt vice versa. So the second part of this study was looking at the PROMIS screening tool, evaluating acceptability and usefulness. We found that this tool was acceptable and that it was straightforward, comfortable with necessary discomfort at times. An example quotation here is that they were all very easy to follow. They flow sequentially, where the first builds off the second. Participants also felt like it was really useful. They felt like it met a critical need and allowed them to generate new ideas or questions. A few quotes here. They were all questions I wish someone would have asked me, and taking this reminded me of those thoughts I had to ask my doctor but had forgotten, basically, is what he was saying. We also assessed qualitatively validity. Now, just a key point, we didn't do a formal validity analysis, but we did assess qualitatively. We demonstrated response process validity. This is the participant's ability to comprehend, recall, make a judgment about recalled information, and find and select a response to the question. An example quote here. Everything made sense and I didn't have any issues with anything on there. I understood everything on there and was able to answer everything to the best of my knowledge. We also demonstrated some construct validity. This was where participants felt like the questions were relevant to sexual dysfunction and to them. These were really important questions to ask and to give real answers to, one said. We also have found content validity. This is that sexual dysfunction across all domains, all types, was evaluated. One participant said it pretty much got the whole range of sexual function. So as I mentioned before, we did do a sub-analysis by age group and gender and didn't find any significant difference in themes across these groups. Notably, females and older participants aged 20 to 24 were more expressive. They were also more represented in the population, as I mentioned, 14 in each of those groups. But they were a little more expressive. However, the other population groups didn't differ in their sentiment, just in how much they talked in quotes that were useful in a qualitative way. So next, I'm going to transition a bit to talk about a framework for the next steps of this work. The Discover, Design, Build, and Test, or DDBT framework, draws from established human-centered design frameworks, applying these methods in a multi-phase process to gather necessary information to drive the creation, adaptation, and testing of stakeholder-centered interventions, as well as to improve implementation outcomes, such as actual use of the intervention. In this case, the intervention we are working to develop is a systematic process to identify sexual function more effectively in clinical settings. Specifically, we want to create a systematic screening process using the PROMIS SexFS brief. This will include how, when, and where to have patients complete this tool, and how to seamlessly incorporate it into an existing clinic flow such that it actually is utilized for clinical care. We also need this to be adaptable to various clinic settings. The qualitative study with patients that we just discussed is part of the Discover phase of this project. The next steps will also be to discover provider preferences and recommendations before working with patients and providers to design, build, and test the intervention. To create a stakeholder-informed, patient-centered intervention, we will first perform interviews with pediatric oncology team members to get an idea of how they think this can work into a clinic flow. After these interviews, we'll design and build an initial prototype through a multidisciplinary team of dissemination and implementation scientists and oncology stakeholders. We will modify this prototype through an iterative process with mini tests in 3 to 5 patients and providers at a time. this is sort of how it will look. So we'll test, update, and keep going like this up to 5 times before finalizing a screening approach. This screening approach will have ways that it can be adaptable to various settings as a result of this process. After developing the screening approach intervention, we will test it using a type 1 hybrid effectiveness implementation trial. Hybrid effectiveness implementation trials simultaneously establish effectiveness and implementation outcomes, identifying multi-level barriers and facilitators to real-world implementation. Type 1 hybrid trials are powered to preliminarily test effectiveness, which is important in this case since the screening intervention will not have been previously proven to be clinically beneficial. Briefly, effectiveness will be measured through changes in patient-reported sexual dysfunction communication and in needs being met, referral patterns, and a few other metrics. The hybrid approach facilitates rapid translation from research to practice by addressing implementation, service, and client outcomes according to D&I science, thus informing adaptability for future dissemination efforts to improve detection and treatment of sexual dysfunction across multiple healthcare settings. Specifically, in our hybrid trial, we will test effectiveness and satisfaction, as well as acceptability, adoption, appropriateness, feasibility, and fidelity of our sexual dysfunction screening approach. Now, I'll just briefly review the long-term aims of this work. If the screening approach is found to be preliminarily effective in a hybrid trial, it will undergo multi-center testing to look at further effectiveness in a number of clinical settings. I hope that this will result in patient-provider communication being improved, as well as improved diagnosis, improved treatment, and reduction of unmet needs. Lastly, of course, the ultimate goal is that we see an improved quality of life in this population. I'll acknowledge now my team members, mentors, and collaborators, as well as funding that has made this work possible. As Leah mentioned, I'm worked through Accords and did a research fellowship with them and have had an immense amount of support from the qualitative and D&I teams there, as well as from a number of people, both at Children's and beyond. Thank you so much for listening. It looks like we have a chat that I'm bringing up now. Just going to read this. Oh, Dr. Coons, and I absolutely should have mentioned this. I apologize. Dr. Coons is mentioning that there is a clinic women's sexual health consult service at university and CCMC that can evaluate patients with these concerns once they are identified. They're evaluated by Dr. Coons, who's a sexual health expert in psychology, and Jessica Pettigrew, who is in the gynecology department. So this is specifically for women with sexual function concerns. Are there any other questions?
Thanks very much, Jenna. I think certainly people on the line should feel free to contact Jenna. She has email across both university and children's email domains. And it seems like there are increasing opportunities for all kinds of great projects, shared efforts, lots of research potential, and a lot of, very, I think, patient-friendly and family-friendly sorts of opportunities to try to really think about how to integrate and improve quality of life.
I see a question from Betsy Risendahl about peer support. There are definitely some studies that have evaluated, particularly I think in breast cancer survivors, using peer support or peer psychoeducation models to address this, and other interventions rather that looked at group psychotherapy or group education processes that had some benefit as well. So certainly I think that would be a kind of resource savvy way to address these concerns once they're acknowledged. I see Winnie Hunter is also a clinical health psychologist working with Dr. Coons. Thanks all.
Great. Thanks everybody. Have a great day.